at the Federal University of Paraná and in Brazil. And we also have myself and Dr. Dallas Smith, a pharmacist, and we're both in the mycotic diseases group at CDC. And here's an overview of what we'll talk about, but we'll just jump right into it. And an acknowledgement of funding and just some housekeeping rules. If you have questions, you can post them to the Q&A section, and we will do our best to hold those questions until the end of the presentation, and the content will be archived online. And so we'll quickly go through the polling questions. I think the first question, it seems like about 3/4 of the audience had heard about antifungal resistant dermatophyte infections before. Next question. And the next polling question is, before this webinar, had you heard about dermatophyte infections spread through sexual contact? So we'll give folks a moment to answer. It looks like maybe about half and half, maybe a little bit, maybe the majority of people have heard about this. All right, we'll go to the next slide, please. And so we're going to start out talking about what's new with dermatophytes. And actually, Dr. Libner will be presenting the first part, and then I'll be presenting the second part. So I will turn it over to Dr. Libner.
So welcome, everyone, and thanks for the introduction, Dr. Gold. Next slide, please. We have no conflicts of interest to declare. So dermatophytosis is referred to as ringworm and tinea. And it's referred to as tinea because tinea means worm, and typically it presents with these worm-like borders. And it's a fungal infection of the skin, hair, and nails, and these are caused by dermatophyte fungi. And the reason it infects these places is because they're rich in keratin, and dermatophytes like keratin. Dermatophytosis is extremely common. There's a 20% prevalence in humans. It can also affect some animals, such as cats and dogs, and some people can even get tinea from their dogs. It's caused by dermatophyte molds, mainly epidemiophyton, microsporum, and trichophyton. And it spreads very easily among people, among their animals, and also by fomites. So it can be spread from infected towels, bedding, sports equipment such as helmets. And typically it presents with itching, scaling, and ring-shaped lesions. And tinea is named for the location that it infects. So there's tinea capitis, which infects the scalp. There's tinea corporis, which infects the skin of the body. There's tinea pedis, which infects the feet. Tinea manum, which infects the hand. There's tinea barbae, which infects the beard area. And tinea cruris, that infects the groin area. Next slide, please. Now, dermatophytosis of the skin is usually mild, and it can be treated with prescription antifungals that are topical, and it can also be treated with topical over-the-counter antifungals. This usually works for most patients. However, sometimes you do have to use oral antifungals, for instance, terbinafine, griseofulvin, the azole family, such as itraconazole and fluconazole. But generally, we use that more for patients that don't respond to topicals, more widespread infections. Another category that may need oral antifungals is those with immunocompromising conditions. Typically, these patients really do have recalcitrant infections. Next slide, please. Now, dermatophytosis of the nails, or tinea unguium or onychomycosis, is a little bit of a different story. It's extremely common. It can be very challenging to treat. So in the general population, the prevalence is about 10%, and that's globally. However, there's higher prevalence in older adults and tends to be not common in children unless they have a household member who also has onychomycosis. We see it far more common in the toenails compared to the fingernails. It's about 10 to 1. And usually if we do see a fingernail dystrophy, it's unlikely to be onychomycosis unless the toenails are also affected. Dermatophytes are responsible for the majority of the infections, and the #1 organism is Trichophyton rubrum, and this is followed by Trichophyton mentagrophytes. There are non-dermatophyte molds that can cause onychomycosis, but on the whole, usually when you culture these out or PCR these out, these tend to be contaminants rather than pathogens. So sometimes you do have to repeat the culture multiple times to see if it's a true positive. Another mistake people make is when they culture out Candida, they think it's responsible for onychomycosis, sometimes for fingernails, but in general, these tend to be contaminants in the nail. And in general, for onychomycosis, we find that oral antifungals are more effective than topical antifungals. Also with the oral antifungals, generally they're shorter courses versus topicals, which generally for toenails have to be used for a year, which is hard for patients to do. Next slide, please. Now, there are some well-known risk factors for onychomycosis, and this was a study we recently published in the Journal of Fungi, looking at a case cohort study of onychomycosis patients versus healthy controls. And you can see that major risk factors are obesity, vascular disease, diabetes, HIV, but the #1 risk factor for onychomycosis is tinea pedis, conferring more than a 10-fold risk. So if you do see scaling on the feet, interweb scale, the chances that this is going to be onychomycosis is pretty high. Next slide, please. Now, it's very important to make the diagnosis of all these superficial dermatophyte infections as well as onychomycosis. And there are many ways you can do this. The cheapest and fastest way is using KOH with microscopy. It's inexpensive. You can get results within minutes. However, it has low sensitivity, it is expertise dependent, and you don't know the viability or identity of the organism. Fungal culture was long considered to be the gold standard for onychomycosis diagnosis because you know both the viability and the identity of the organism, but it's a slow process. It can take several weeks for results, and there's a very high false negative rate. Histopathology is one of my favorites because you have the ability to diagnose other conditions such as nail psoriasis. You get results within days. It's very sensitive, but again, you don't know the viability or identity of the organism. PCR is a newer technique. It is really fantastic in terms of its sensitivity, its specificity, and its speed. You can know the identity of the organism, but not the viability, and you do have to clean well to make sure there's no contaminants. Next slide, please. Now, dermatophytosis is not just a cosmetic concern. Patients are typically very itchy when it affects the skin or the scalp. It can cause hair loss in the case of tinea capitis. People may be afraid if someone has an infection of their skin, nails, or scalp that could be contagious. It often causes a decreased quality of life. People will miss school and work. And in some populations, such as those that are immunocompromised or diabetic, there's the potential for bacterial superinfections, and this can lead to amputations in diabetic patients. It has a substantial healthcare burden, and so it's important to treat, and it's very spreadable. So especially in shelters, nursing homes, schools, this can be transmitted, and so it's important to treat. Next slide, please. Now, with dermatophytosis, looks can be very deceiving, and this goes both for the skin and the nails. So in the top of the slide, you can see that all these nails look like onychomycosis, but only one of them is, and that's the first one. The second one in the middle, that's nail psoriasis, and the third is a squamous cell carcinoma of the nail. And so if you were to treat the second two cases with an antifungal, #1, the patient would get worse in the middle, and in the third case, this patient could get an amputation, or this could even lead to death. And in the photo below, you can see that it's hard to distinguish between eczema and dermatophytosis. And this really just drives home why confirmatory diagnosis is so important. I'd like to thank you for your attention, and I will reintroduce Dr. Gold for the next part of this talk.
And so we can see that even without the component of antifungal resistance, dermatophytosis is an important public health concern and clinical challenge. And we've really been seeing, in the past at CDC, we focused more on invasive fungal infections, but more recently we've been concerned about superficial fungal infections, as increasingly so because of antifungal resistance emergence. We've been seeing antifungal resistant dermatophytosis become a major problem in South Asia, and this is because of a new pathogen, a recently emerged fungus. It's called Trichophyton indotineae, and this is sort of the dermatophytosis caused by T. indotineae is different from what we think of with classic dermatophytosis. It's much more severe a lot of the time. It usually causes infections in the groin, extremities, body, and face, and occasionally nails may be involved too, but that's less common. And what's particularly concerning about Trichophyton indotineae is not only does it spread easily person to person, but it's often frequently resistant to terbinafine, which is oral terbinafine, which is, as Dr. Lipner mentioned, an important option for patients who have more severe dermatophytosis. And sometimes T. indotineae is resistant to itraconazole, which is sort of the second-line oral treatment for dermatophytosis. And like I mentioned, it spreads easily person to person. Next slide, please. And what we really think has sparked the emergence of T. indotineae and other drug-resistant dermatophyte species is the use of creams that contain highly potent steroids, antifungals, and sometimes antibacterials. And in other parts of the world, these sorts of combination products that contain the high potency steroids can often be purchased over the counter without a prescription, and patients might experience initial relief because of the steroid, which might help with the inflammation, but ultimately that can make the fungal infection much worse, and patients have these like persistent fungal infections which are in the presence of antifungals, and sort of creates a breeding ground for resistance. Next slide, please. And by 2023, so this is maybe a decade ago that we started seeing the emergence of T. indotineae, but by 2023, there were cases of T. indotineae infection detected in 6 continents. Most of the cases are still localized in the South Asia region, but it's really become a global phenomenon and cause for public health concern. Next slide, please. And so we actually at CDC, in collaboration with dermatologists in New York City and the New York State Department of Health, the Wadsworth Center, and the New York City Health Department, we published on the first cases of T. indotineae documented in the US. And just some of the key, you can see from the photos just sort of how extensive these patients' infections were. And these patients had substantial diagnostic delays and received multiple rounds of antifungal treatment, of ineffective antifungal treatment. And despite these patients being immunocompetent, they had pretty substantial infections that were really affecting their quality of life. And one patient had a known exposure to someone else in Bangladesh who had a similar infection, but the other patient didn't have any known exposure, and it kind of sparked concern for potential local US transmission. And since that paper was published, there have been cases of T. indotineae detected in well over 10 US states. And that's just sort of, we think, the tip of the iceberg. Next slide, please. These results were expanded on in a case series that was performed actually by the same group of researchers and public health officials, kind of looking at the first 11 cases from New York City. And again, what we saw were extensive diagnostic delays, a frequent failure of terbinafine therapy at standard doses, and patients needed, most of them needed prolonged itraconazole courses, often on the order of 2 to 3 months in order to achieve cure, and relapse can be very frequent. I won't go into, for the sake of time, I won't go into all the details, but there was a nice whole genome sequencing component to the study, as well as squalene epoxidase mutation testing, and that's sort of the mutations to that gene can confer terbinafine resistance. So for those interested, there's a lot of interesting detail in that paper. Next slide, please. I did mention T. indotineae infections of the feet and nails have been documented or suggested, but for the most part, the T. indotineae seems to have a predilection for the skin on the trunk, arms, groin, and face, but there was one case report of suspected T. indigeniae infection of the nail that I saw recently from Italy. So I just wanted to highlight that as a possibility. Next slide. In addition to T. indigeniae, in the United States, we've already been we've been closely following the emergence of drug-resistant Trichophyton rubrum. Similar to T. indigeniae, Trichophyton rubrum that's resistant to terbinafine can be quite difficult to treat and cause extensive infections. In this case series from Dr. Lusky at the University of Alabama, the patients actually ended up requiring posaconazole to ultimately be able to treat their dermatophytosis, and that's a drug that's ordinarily reserved for people who have weakened immune, for people with invasive fungal infections or for prophylaxis against invasive fungal infections. We're really not happy to be in a place where we have to use a drug like posaconazole for treating a superficial fungal skin infection. Next slide. We've also been hearing more about cases of terbinafine-resistant Trichophyton rubrum, which we're finding that may be an important contributor to onychomycosis treatment failure. This is a study actually that I worked on with Dr. Lipner and other colleagues from Cornell, basically looking at the clinical histopathologic and mycologic features of patients who had mycologically confirmed onychomycosis and failed oral terbinafine treatment. And we did identify at least 2 patients with squalene epoxidase mutations that are associated with terbinafine resistance. So it's something for clinicians to keep in mind that this may be a cause. There are a lot of reasons why patients with onychomycosis might fail terbinafine treatment. One of the most common is probably, I wonder whether some patients may not actually have onychomycosis and we're just treating them unnecessarily with antifungals, but that's a separate discussion. But next slide. But this issue of terbinafine resistance in onychomycosis is certainly a growing cause for concern. There was a very large-scale multi-center study done by Dr. Gupta and other colleagues looking at the prevalence of terbinafine resistance confirmed squalene epoxidase mutations among Trichophyton isolates. And I won't go into all the details for the sake of time, but basically they found that about 4% of those isolates on which they could identify Trichophyton had these squalene epoxidase mutations that have been correlated to terbinafine resistance and treatment failure. Next slide, please. Another emerging concern is dermatophytes as a potential cause of sexually transmitted infections. And I wanted to point out that with Trichophyton indigeniae, there was actually a recent report published in Emerging Infectious Diseases, a patient who had genital dermatophytosis caused by Trichophyton indigeniae, that she likely acquired that infection through sexual contact with a partner in Bangladesh who had similar lesions. And her infection was resistant to terbinafine, and she really had a lot of substantial diagnostic delays and inappropriate treatment, including corticosteroids, which made the infection worse. And similarly, there's another emerging dermatophyte species called Trichophyton mentagrophytes genotype VII. It's not the catchiest name, but we call it TM7. And this is an emerging, this strain of dermatophyte has been circulating in Europe, particularly in France, among men who have sex with men for several years. And actually, our colleague, Dr. Kaplan at NYU recently reported on the first U.S. case of T. mentagrophytes type 7, also in a man who had traveled to Europe and also spent some time in California and developed a genital dermatophytosis caused by Trichophyton mentagrophytes type 7. So I just wanted to highlight this as an emerging cause for that clinicians, an emerging pathogen that clinicians should be aware of in patients presenting with genital lesions. There's a possibility of fungal infection. And also I wanted to take a moment to plug a new resource that was just put together by the American Academy of Dermatology in consultation with CDC subject matter experts. And it's a resource on Trichophyton indigeniae and other severe or antifungal resistant dermatophytoses. So really like the species that we just discussed. And the website has information sheets on disease diagnosis, prevention, treatment, and sort of provides information on which labs do the testing and sort of all the contact information, how to counsel patients, just a lot of information that can be helpful for clinicians of all practice types if they encounter patients with suspected dermatophytosis from one of these emerging pathogens. Next slide. And just some quick pointers about testing for resistant dermatophytosis. We really think the burden of resistant dermatophytosis is underestimated in the US because testing is not widely available. And also culture-based techniques do not reliably distinguish T. indigeniae from other species of Trichophyton. So you need advanced molecular techniques that are not available at most laboratories. And I won't go into all the details because I know we just speed it up a bit. So, but if a lot more information is available on the AAD website. And next slide, please. And again, for the sake of time, we won't go through all of this, but really we want to emphasize that severe and emerging dermatophytosis is an emerging public health concern, and we're trying to raise awareness among public health officials, particularly about the resources from AAD that can help with help clinicians have the tools they need to be better prepared to treat these patients. And there's also a need for antifungal stewardship to improve to promote appropriate use of antifungals and to avoid overuse of and I'm talking about both oral antifungals and topical antifungals, as well as trying to minimize inappropriate use of corticosteroids, particularly antifungal corticosteroid products, which we're finding in our research tend to be frequently prescribed in a manner that may not be appropriate. So I will turn it over to Dr. Smith and Dr. Quiros Tellez. I think first is Dr. Quiros Tellez. So looking forward to his presentation.
Hello, good afternoon from southern Brazil. Can you see my screen? Can you see my screen? Yes? Hello? Hello? Can you see my screen? Okay, let's go. Well, I'm Flavio Tellez from Curitiba, south of Brazil, and now we're gonna move deeper in our human bodies because we will left the superficial and cutaneous infection. And I would like to say something about the implantation mycoses. Well, you know that when you get infected but by an endemic fungi, this fungi can infect you by the respiratory route, like paracocci, like histo, like crypto. But there are some thermodermophic fungi that they are implanted through your skin or into your mucosa. Okay. To the right, you can see a nice picture from my friend Professor Boniface, showing a piece of wooden split deeper into the skin of a person. Well, in the past, we also call it subcutaneous mycosis, this group that of heterogeneous group of fungal disease that they develop at the site of a transcutaneous or transmucosal trauma. Well, the etiologic agents are saprops. They are low virulence fungi, and most of them nidimorphic. So I don't use the term subcutaneous mycosis anymore because in most of this disease, fungi affect the skin, subcutaneous tissues, lymphatic, bones. You can see to the right a picture showing the infection of a sapronotic sporotrichosis caused by plant debris. No, sporotrichosis is also known gardener's disease, but now I will show you to the right, in the right, a foot, an amputated foot of a patient that we treated some years ago. This foot weighed more than 5 kilos, and you can see that you can't tell that this is a subcutaneous mycosis. This is an implantation mycosis. Everything is destroyed in this foot. Interesting. There are several diseases called implantation mycosis. In the first hole, you see 3 hands, sporotrichosis, chromoblastomycosis, and mycetoma. And in the bottom, some implantation mycosis that are more infrequently or rare, like lobomycosis and tomophthalomycosis and hyphomycosis. And it's very, very interesting because in the veterinary medicine, you can see all these implantation mycosis in different kinds of animals, except for chromoblastomycosis. No, so the implantation mycosis may affect human and non-human animals. Talking about the public health, there's a paper in the US showing that in the rural areas, there are 7 injuries per 100 workers in the US. And this is a substantial number of cases of implantation mycosis. You know that they are secondary to these injuries. I know that in Latin America, especially Brazil, they are more common than in the US. But in Latin America, there's a lack of data on prevalence, economic, and social cost of the implantation mycosis. So the rural workers are one of the most individuals in risk for those infections. Let's start with the most common implantation mycosis in Brazil and in the world, sporotrichosis. You know that there are 2 main kinds of sporotrichosis: the sapronotic, which is transmitted by plant soil or plant fragments, and the zoonotic sporotrichosis. There are many species of sporotrichs causing this mycosis, and they need molecular biology to be identified. I want to tell you about Sporotrichs brasiliensis. Sporotrichs brasiliensis is causing a huge outbreak in Brazil and now is spreading in South America, in some South America countries. Sporotrichosis is interesting implantation mycosis because it may cause clusters of case outbreaks, and it is an occupational disease. In Brazil, sporotrichosis by Sporotrichs brasiliensis is now called the cat disease. In the rest of the world, sporotrichosis is the gardener disease, but here is the cat disease. If you take into account the virulence studies of the different species of sporotrichs, you can see that Sporotrichs brasiliensis is the highest, the most virulent species among the other causing the disease. It is very thermotolerant. It can produce a lot of melanin, a pathogenic, a virulence factor. It produces biofilm in vitro and in vivo, but the most important pathogenic or virulence factor is that Sporotrichs brasiliensis is the only thermodimorphic fungi that can be transmitted directly in the yeast phase. No other dimorphic fungus can do this. Stoplasma, Paracocci, Sporotrichs schenkii. The brasiliensis can be transmitted from yeast to yeast, from cat to man to dog and to other cats. We are observing the jump of the cat in terms of incidence of sporotrichosis, cat-transmitted sporotrichosis in Brazil. It started in the state of Rio de Janeiro in the 2000 and is growing without control. Here you have data from the Fiocruz, Rio de Janeiro. In 2012, more than 4,000 cases in humans, almost 4,000 in cats, and more than 100 in dogs. After, this number increased, involving more humans, more cats, and more dogs. And now this outbreak expanded to other South American countries like Uruguay, Argentina, Paraguay, and Chile. In 2019, the World Health Organization published an alert in the internet about this emergent fungi, Sporotrichosis brasiliensis. And the interesting is the different from the Schenki or globosa species. Sporotrichosis brasiliensis can be transmitted by exudate, direct contact of exudate with skin, and by the sneeze of the sick cat. The cat who has involvement of the nose, of the face, he has sneezing episodes, and it can transmit the disease to humans and to other cats. The gold standard diagnosis method for sporotrichosis is culture. Direct exam and histopathology has a sensibility less than 30%. And we try to validate, we started to validate a lateral flow assay together with the EMI in US. And our pilot study showed that this is a promise. It's a good test. It has around 80%, 83% of sensibility and 82% of specificity. But we have to validate this test in the future. How do we treat sporotrichosis? Well, the best drugs are itraconazole and terbinafine. We need a clinical trial to compare itraconazole versus terbinafine and this mycosis. This study is needed. And for the most severe case, like fungemia, like disseminated form, meningeal sporotrichosis, we should use lipid amphotericin B. There are no resistance of Sporotrichosis brasiliensis to the antifungal. All these samples, the isolates causing sporotrichosis, are very susceptible to itraconazole and or terbinafine. Here you can see a patient with ocular sporotrichosis before and after itraconazole. In Brazil, around 10% of the case are ocular forms, especially with granulomatous conjunctivitis and dacryocystitis. Second disease, chromoblastomycosis. This disease is the second most prevalent implantation mycosis in the world. It is expected that we have 10,000 new cases per year. There are several areas of high endemicity, I will show you in a moment. And this disease has a chronic evolution. It may affect the cutaneous and subcutaneous tissues. It produces a granulose and purulent tissue response and non-protective humoral or immune reaction. Except for the initial lesion, it is very hard to discover, except for this lesion that you can treat surgically by excision. Most of the case evolves to moderate to severe forms, and they require long period therapy with antifungal, especially itraconazole. Some patients with very severe forms of the disease are refractory to therapy. This is a paper from Dr. Santos, Brazil, showing the prevalence of chromoblastomycosis. You can see that in the highest prevalence is in Madagascar, Botswana, and here in the Caribbean. No? The disease is reported around the world, including in US. There are some interesting cases in US after hurricanes, after snake bite, but the most common mode of transmission is by plant fragments. There are more than 10 species of melanized fungi causing chromoblastomycosis. You need molecular biology to identify the species. The most common agents are from the genus Fongacea, like Fongacea pedrusoi monophora, and we have also Cladophyalophora carrioni and Phyalophora veicosa. There are many other agents that are sporadic agents. All of these agents present as a muriform or sclerotic bodies in tissues. They are chestnut, they are melanized, they are pathognomonic in diagnosis. All the agents are treated in the same way with antifungals, systemic antifungals, especially itraconazole, posaconazole, or itraconazole associated to terbinafine. Here you can see a rhythm of diagnosis. Your microscopy is very sensitive. Even direct examination or histopathology. The melanized fungi, they are black fungi. They have a slow growth. They present slow growth colonies. You can see giant cells with multiform bodies, and you can, when you see your patient, look at for black dots, this dark points, and here you will collect your material and find the agent. Okay, there are some PCR-based methods, in-house PCRs, but they are not available in most centers. You need only a microscope and a culture media to make diagnosis. You can graduate the lesions of your patients according to the severity. This graduation helps to plan the therapy. Initial lesion must be treated by surgery, and mild form, moderate form, you can see to the right, and severe forms, you use antifungals, the combination of physical medicine and antifungal, or combination therapy. It's a challenge to treat a severe case of chromoblastomycosis. This is a picture from some of my patients. 3 diet from sequela of chromoblastomycosis due to the extensive chronic inflammatory process leading to the accumulation of collagen fibrosis. This is a terrible disease if not treated in time. Last disease is mycetoma. It is expected that we observe around 8,000 new cases of mycetoma around the world. We have actinomycetoma and eumycetoma. In Brazil, in Latin America, we have the prevalence of actinomycetoma caused by several bacteria from the actinomycetalis order. And this disease is when in its full picture, it is characterized by edema, tumorous lesion with multifistulas, which produce an exudate with grains, little grains. These grains are small colonies of the etiologic agents. 70% of the clinical presentation occurs in the lower legs, like this patient from my hospital. It is an implantation mycoses. You can see a piece of wood implanting the agents of mycetoma. Here you can see the global burden of actinomycetoma and eumycetoma. You can see that India, Sudan, and some parts of Latin America, especially Mexico, has the greater number of cases per year. Most of the patients are located in the tropical zone. We have this, call it the mycetoma belt in the tropical and subtropical area around the globe. This is an interesting review published by Professor Hay, showing that the main diagnostic methods to discover these three mycoses, mycetoma, chromo, and sporo. You can see that clinical features are very important, but microscopy is not important in sporotrichosis, but is important in mycetoma and chromo. The same culture is important in the three diseases. Serology, it presents very low results. We have no commercial methods, and molecular diagnosis is usually made in-house. Histopathology is most important for mycetoma and chromoblastomycosis. Regarding therapy of eumycetoma mycetoma, itraconazole is the most useful drug. We can also use posaconazole if it is available. There is an investigative triazole, the phosphohavoconazole, in a clinical trial in Sudan. But the most important is to treat early. And if you cannot treat, you should submit your patient to surgery, usually an amputation. Now, we have some polling questions. I don't know if I should leave my full screen presentation to show you these polling questions. Yes? Okay. Well, especially for you living in the US, have you seen a patient with an implantation mycosis, locally acquired? No, yes, mycetoma, chromosporo. What do you think? Please answer this polling question. And Dallas, please tell me when I should show the second polling question. Yes? Okay, thanks for your help, Dallas. Second, have you seen a patient with implantation mycosis locally acquired outside the United States? Maybe a refugee, an immigrant, short-term valor. It is a traveler disease, can be a traveler disease. I can assure you that cat-transmitted sporotrichosis, it is a travel-acquired disease for those visiting the endemic areas in Brazil. But you can answer. Okay, Dallas? Yeah. Well, my last slide about the implantation mycosis. I think that everybody agree that they are a public health problem in low-income countries around the globe and being associated with substantial morbidity. Remember chromoblastomycosis, mycetoma. The dynamic changing in the epidemiology of this mycosis seems to be closely associated to anthropic and natural environmental changes, especially when we talk about zoonotic sporotrichosis and in part of chromoblastomycosis. There are some environmental change affecting the epidemiology of this disease. They are neglected skin disease. They are researchers. They are neglected by researchers, including there's a few papers on this disease in publication. The lack of compulsory notification for the implantation mycosis obscures its real burden and diminish its visibility. Uh, uh, Although itraconazole is the first-line recommended drug for most implantation mycoses, it is currently not provided free of charge in most of the medical centers in the globe. In Brazil, this is an exception, where our government gives free itraconazole to all patients with endemic mycosis, including implantation mycosis. Thank you for your attention. Dallas?
Thanks so much, Flavio. And before I begin my section, I just want to let everyone know that we're going to stay on an extra 10 to 15 minutes, just so we can answer some of your questions too. But we really are really interested in sharing these data that we have about fungal neglected tropical diseases in the United States. Next slide, please. And so what we wanted to do was we wanted to determine the burden, or just get an idea of the prevalence of implantation mycoses, also known as fungal neglected tropical diseases in the United States. And so what we did was we analyzed market scan data, which is a database that uses insurance claims. And we looked at US patients from 2017 to 2021. And we calculated 5-year prevalence rates for some of the most common implantation mycoses. And what we found was that chromoblastomycosis, which included phaeohyphomycotic abscesses, was the most common implantation mycosis. But we also saw high prevalence rates with sporotrichosis and mucormycosis. Eumycetoma was pretty rare. And then we look at talaromycosis, lobomycosis. It was very, very rare. Next slide, please. But we wanted to take this a step further. So we're looking and comparing implantation mycoses, but what if we look at other common skin neglected tropical diseases that are not fungi? And so what we found was that chromoblastomycosis, like I said, including these phaeohyphomycotic abscesses, was more common than leishmaniasis and onchocerciasis and leprosy, and some of these other skin NTDs that get much more attention, much more funding, and people are just more aware of these diseases. And as you can see, sporotrichosis was also pretty common compared to some of the other skin NTDs. And so these are problems even in the United States that we need to increase awareness and improve care for these patients. Next slide, please. And when we look at some of the demographic and clinical variables for these patients in this data set, we saw that it differed from other parts of the world. One of the most noticeable differences was that most of these mycoses, prevalence generally increased with age, and it was highest among those aged greater than or equal to 65 years of age, which when we look at globally, we normally see young, healthy individuals acquiring these diseases, maybe people in their 30s to 40s. We also, for reasons we're not really sure, we saw a female predominance for eumycetoma. This was a pretty small sample size, and so we didn't look too much into that. But another interesting aspect that we found was that immunosuppression was significantly associated with each of these implantation mycoses. Even when we broke down chromoblastomycosis and differed it from phaeohyphomycosis, chromoblastomycosis was still significantly associated with immunosuppression, which was interesting because we normally think about these implantation mycoses affecting healthy individuals. Next slide, please. However, this administrative data set had several limitations. There was gaps on data on race ethnicity, reliance on these insurance codes. We didn't know if they were locally acquired versus imported. And one of the most problematic areas was distinguishing between chromoblastomycosis and phaeohyphomycosis. And so we needed different approaches to understand these diseases that don't rely solely on administrative data sets. Next slide, please. And so what we did, that we wanted to perform a retrospective review of medical records of eumycetoma and chromoblastomycosis at 9 US medical centers. Next slide, please. And so our objectives, and I won't read this off, but we really just wanted to better understand the demographics, the clinical characteristics at a more fine level than just using administrative data. Next slide, please. And so these are our partners that we've worked with to do this retrospective review. As you can see, we have a pretty diverse geographical representation of the United States. And so we have the East Coast, Midwest, East Coast, South, all represented. Next slide, please. And so we collected case data from January 2005 to August 2023. We utilized a standardized case report form. And initially, in the data that I'll present today, we only included eumycetoma and chromoblastomycosis. However, we recently added sporotrichosis, and chart abstraction is still ongoing. We included all causative organisms, but we did exclude phaeohyphomycosis and actinomycetoma. Next slide, please. And so data extraction is still ongoing, even for chromoblastomycosis and eumycetoma, but I do want to present some preliminary data on 49 chromoblastomycosis and 9 eumycetoma cases from 6 medical centers. Next slide, please. Next slide, please. And so I'll start with the chromoblastomycosis data, but the demographics in terms of age and, in terms of sex was pretty similar to what we see globally. A lot of them were male, most of them were non-Hispanic, a lot of them were white. Average age was 63, which was a little higher than we expected, looking at global averages. And what was interesting was 30% of them were retired, which kind of most likely reflects the average age of patients. Next slide, please. And when we looked at some of the immunosuppressed versus non-immunosuppressed, many of them, a good majority, 73%, were immunosuppressed. And when we look at the immunosuppressing conditions, 59% received solid organ transplantation, the most common being kidney, followed by lung. And 43% of the disease had immunosuppressive therapy. I do want to note that many of the centers we partnered with had a big transplantation unit, and so that could have biased our data a little bit in terms of the immunocompromising conditions that we saw. However, other common comorbidities include diabetes, which was about 40%, and chronic kidney disease, which was about 40% as well. Next slide, please. And so when we looked at some of the travel-related history, we found that around half of the patients, so 29, had no lifetime international travel. And when we dug in a little more, we found that 10 of them actually were called traumatic inoculation. 3 of these were in Alabama, 2 in Tennessee, and 1 each in Florida, North Carolina, Hawaii, the country of Laos, and 1 on the African continent. The country was not named in the medical record. But if you look at the right-hand side, these are some of the traumatic inoculation events that these patients were called. And so the first one was this pretty common plant, tropical plant in Hawaii. They were stuck by it by a thorn. The next one was when a patient was cutting down a tree in Florida. He was stuck by some of the tree limbs, and that was facilitated the traumatic inoculation of the fungi that caused chromoblastomycosis. Another one, which was interesting, was brushing up against concrete in Tennessee. And finally, one of the other ones I wanted to share was this regular yard work in North Carolina. And so it shows the diversity of ways that chromoblastomycosis can be acquired in the United States. Next slide, please. And so when we looked at healthcare seeking behavior, we saw that 27% of patients had 1 or more misdiagnoses. And the most common misdiagnosis we found was skin cancer, specifically squamous cell carcinoma, which we've seen in the literature in the past. And I can almost guarantee some of my dermatologist colleagues will say that these look pretty similar, especially in early disease. I listed quite a few other misdiagnoses on the right-hand side, but just really wanted to call out that skin cancer misdiagnosis. Next slide, please. The incubation period and time to diagnosis were over several months. And these are pretty small sample sizes because not all the data could be obtained from a medical record. But we found that from the time of exposure to symptom onset was about 5.5 months. And this was, like I said, a pretty small sample size N of 4. But that's an incubation period of about 6 months, which is pretty long. From symptom onset to diagnosis was 4 months. And from symptom onset to resolution was about 6 months, which especially the symptom onset to diagnosis was much shorter than we've seen in other parts of the world. Next slide, please. When we looked at some of the culture data, we found that 33% of cases had culture data available. And on the left-hand side, you see that some of the fungi isolated. So we saw 6 Esophilia species, 3 Fonsecaea, one Phyllophora, one Bipolaris, and some other fungi that are mixed in, but just highlights the diversity of fungi that we even see in the United States that cause chromoblastomycosis. Next slide, please. And so when we looked at the clinical presentation and severity of chromoblastomycosis, we saw that most infections were on the upper limbs, 67%, which kind of differed from what we see globally, which more infections typically occur on the lower limbs. Common presentation and symptoms were nodules, which is about 49%, raised and crusted lesions, 22%, and we saw that 22% did experience pain. And most infections were of mild severity, and this is based on the severity score that actually Flavio, our previous presenter, developed and published a couple years ago. Next slide, please. And so when we looked at treatments in terms of until clinical resolution, so this chart only includes those who had clinical resolution, we saw that itraconazole was used most commonly in 18 patients. The average length of therapy was 197 days, but you can see that the longest time period was 700 days that a patient was on itraconazole. Some toxicity that occurred was nausea and vomiting and a rash. The next most common agent was posaconazole. It had a little shorter average length of therapy, about 100 days, but as you see, the longest was still 215 days. Voriconazole and terbinafine were also used. Terbinafine had a very similar average length of therapy as posaconazole, but if you look at terbinafine actually had a much longer average length of therapy than we looked at the other azoles. These are pretty small sample sizes, but we think it is still pretty interesting. I also wanted to note that about 33 patients had surgical lesion excision as well. Next slide, please. And then, so most patients, as I mentioned, had complete resolution of lesions, but some serious complications occurred nevertheless. And so 4 of them had recurrent lesions, 3 had tissue fibrosis, 1 had internal organ involvement, which was the bone, and 1 had lymphedema. And as I mentioned, 67% were noted to have completely resolved lesions. The other 33% were lost to follow-up or were still ongoing treatment at the time of data collection. Next slide, please. And so that was chromoblastomycosis. Now I want to shift briefly to eumycetoma. As I mentioned before, we only have 9 cases of eumycetoma, so this will be pretty brief just because we're limited by our data. Next slide, please. And so demographic data was consistent with global trends. Most were male, and the average age was 57, which maybe was a little higher than we expected, just based on previous estimates that we've seen in the 20s and 30s of where most people acquire mycetoma. And only 2 patients with eumycetoma were immunosuppressed. And so this was pretty rare that people were immunosuppressed, but as I mentioned, this is a pretty small sample size. Next slide, please. Travel and cultural data were also limited. We did have 3 patients that were called traumatic inoculation, and 2 of them did occur in Alabama, and the other one was in Vietnam, the country of Vietnam. 6 had culture data, and all 6 of these fungi that were cultured have caused mycetoma in the past from previous publications, and so nothing stuck out here. But you see that Fusarium was a causative species, Scedosporium, Exophiala, and so some of these fungi kind of represents the diversity of fungi that can cause mycetoma, just like the diversity that can cause chromoblastomycosis as well. Next slide, please. And so more data are needed on clinical presentation and treatment in the United States and globally. What was interesting, we saw that most patients did experience pain, which kind of, when we think about mycetoma, we think of a large painless lesion, but many of our patients noted that they did have pain. 8 patients had lesions on the lower limbs, which was consistent with what we see globally. For treatment-wise, 5 patients received voriconazole, which was interesting because we normally think about people getting itraconazole first line. And the 5 patients had local surgical excision or surgery. Next slide, please. And so next steps in conclusion. So we want to continue to collect and analyze data on fungal NTDs. We have, like I mentioned before, we have ongoing case collection for sporotrichosis. And we want to add additional sites to submit eumycetoma and chromoblastomycosis data as well. One of the other things we want to do is for chromoblastomycosis and even sporotrichosis, we want to classify cases as suspect versus confirmed. Some of the chromoblastomycosis cases that we included could have been cutaneous phaeohyphomycosis, especially when we think about some of the fungi that we identified. However, these are treated relatively similarly, and so we think they are still medically important, but it would be good to classify them as confirmed chromoblastomycosis through the identification of myriform bodies versus suspect cases which may not have done microscopy or histopathology. And so we're working through that process right now. However, if you are interested in participating, please reach out to me at rhq8@cdc.gov. We would love to have your partnership in this project. Next slide, please. And so take-home points: clinicians should be aware of locally acquired and travel-associated cases. We want to continue surveillance that could increase disease recognition. We think these clinical data can inform guideline development, which no standardized guidelines exist right now globally. And we also want to monitor for local acquisition and causative organisms, because we want to see if climate change or migration-related shifts could change the geographical distribution of these fungi, which we think could be really important going forward. Next slide, please. And thank you all so much. We would love to take any questions you may have at this point. And sorry again for the technology troubles at the beginning.
Thanks so much, Dallas, Dr. Smith, and all of the presenters on the call today. There is one question from the audience, and I think this is probably good for either Dr. Smith or Dr. Tellis. So the question is, it's up there. In patients receiving itraconazole for implantation mycosis or terbinafine-resistant tinea, do serum levels correlate with response?
Very curious what Flavio thinks, but I think we don't have enough data to have this correlation currently. I think the problem is if we have a serum itra level, what does that mean in terms of how much drug is getting into the skin? I don't think we have those data to even figure out, well, we have this much in the serum. How much does that correlate to having in the skin? And then how much in the skin, what does it correlate to clinical response? And so I think it's a very interesting question, but I'll see what Flavio thinks as a practicing clinician too.
Well, this is a good question. Unfortunately, we don't have itraconazole serum levels in Brazil, but we're starting a project with our friends from the Netherlands. We start to dose itraconazole in serum of patients with sporotrichosis taking itraconazole. But for other disease like chromo, we have no data. And maybe there is a correlation. If you have lower level, you get better response, but we have to prove this. No. Another comment, Dallas and friends. For these very refractory cases of chromoblastomycosis, it's very important to know that itraconazole and flucytosine, it works very well. We have some published case, the association of itra and flucytosine. It's a good chance for these refractory cases.
And I would say for terbinafine-resistant tinea, similarly, we really don't have great data to answer that question, unfortunately. It's definitely an area of research interest and clinical importance. I don't see any other questions remaining. So again, we apologize for the technical troubles in the beginning and appreciate those sticking with us. And thank you so much for the opportunity to talk about these superficial fungal infections and implantation mycoses, which we think are of growing importance around the world clinically and from a public health point of view. So if you have any questions, we hope people will feel free to reach out to us. And we wish everyone a wonderful rest of the day.